Hello and welcome back. Today I'll be talking about our third part in the echocardiography for an internist. So we'll be using the physical exam in the context of echo to understand the patient's hemodynamic pathophysiology. So what we're going to do is we're going to take a detour back through our understanding of physical examination, and you might ask yourself why. Okay, so the reason for this is sometimes what happens is that as a internist or as a non-organ specialist, subspecialist, what happens is, say I have a patient with systemic sclerosis, and the patient has chronic shortness of breath. I send the patient over to cardiology suspecting a diastolic dysfunction or a heart failure. Okay, and the report comes back saying there is diastolic dysfunction. Okay, now the issue that then remains: is it diastolic dysfunction due to a ventricular cardiomyopathy or restrictive cardiomyopathy, or is it due to fibrosis of the pericardium? Okay, that is constrictive pericarditis. So both of those possibilities exist. However, a restrictive cardiomyopathy, particularly that affecting the left ventricle, would explain the chronic shortness of breath. Okay, it is compatible with our diagnosis, so has a higher pretest probability. However, a constrictive pericarditis would not per se explain the shortness of breath unless the patient had features of right ventricular failure that were predominating. That is, the patient had peripheral edema, ascites, right upper quadrant pain, a tricuspid regurgitation, murmur, things like that. So, in this situation, a detailed physical examination helps us out, and this is what we're going to see today. So, the first thing that we'll see is, thinking back, what are the parts of the physical exam that give us valuable information about ventricular diastolic function? So obviously it is only these three. That is, we can do a pulsus paradoxus, that is a BP finding, okay, not a pulse finding, as we have previously discussed. Then we can look at the JVP waveform. Okay. Third is we can look for the S3 sound, which corresponds to early rapid filling, and the S4 sound, which corresponds to the atrial contraction. Okay. S3 happens when you have rapid ventricular filling. Okay, usually but not exclusively when there is impaired ventricular dilatation. Okay, and similarly an S4 occurs when there is atrial contraction against a non-compliant ventricle. Okay, so typically indicating hypertrophy. So clinically, when a patient comes to me with echo report suggestive diastolic dysfunction, what goes through my head is the following. On one side, I take Kussmaul sign. Okay, I assess the patient's Kussmaul sign. I would have done this prior to sending the patient for echo, but just bear with me. On the other hand, I look at whether the patient has a pulsus paradoxus. Okay, so the Kussmaul sign may be present, it may be absent. Okay, similarly, pulsus paradoxus may be present, may be absent. Now, if the Kussmaul sign is present and pulsus paradoxus, rather, if the Kussmaul sign is absent and pulsus paradoxus is present, so what we say is that the patient likely has cardiac tamponade. Now, on the other hand, if Kussmaul sign is present but pulsus paradoxus is negative, okay, it is absent, then we consider a rich differential diagnosis, that is these four entities, that is restrictive cardiomyopathy, RV myocardial infarction, constrictive pericarditis, and RV hypertrophy. Now, on the other hand, if both are present, that is Kussmaul sign and pulsus paradoxus are present, then it is an entity that falls in between in the pathophysiological spectrum from cardiac tamponade to constrictive pericarditis. So what happens is, during acute effusions within the pericardial sac, you can get tamponade physiology, you may not get tamponade physiology. Now, when you do have some tamponade physiology and then the patient, however, survives, say we put, the patient undergoes pericardial paracentesis and survives, later on that effusion, if there is any residual effusion, can organize and there can be a Th2 polarized response resulting in fibrosis of the pericardium. So as the pericardial fibrosis progresses, there is a stage in between when there is a positive pressure within the pericardium and there is pericardial fibrosis. So that condition is called effusive constrictive pericarditis. Okay, and it actually falls in between cardiac tamponade and the constrictive pericarditis. Therefore, it tends to have findings of both. So you get findings of cardiac tamponade almost exclusively, as in you get almost all of the findings of cardiac tamponade. So you will get a large A wave, you will get a decreased Y descent, an exaggerated X wave. Okay, so these will be the findings, and on echo also you will get findings suggestive of cardiac tamponade. These two conditions therefore would not present with chronic shortness of breath, particularly cardiac tamponade. Effusive constrictive pericarditis might, but we'll be discussing these entities under the heading of an approach to acute shortness of breath. Okay, so that leaves us with what? It leaves us with our rich differentials. So another thing that we need to discuss is that restrictive cardiomyopathy usually has neither pulsus paradoxus nor Kussmaul side, but may have a Kussmaul side positive. Okay, but that is an uncommon finding. Okay, fine. Now, how do I approach our rich differentials? So what I do is I divide them based on their clinical manifestations. Some of them are more similar to each other than the others. Okay, so first what I do is I compare restrictive cardiomyopathy to constrictive pericarditis. Okay, very close differentials as would be expected from our understanding of physiology. So both of them actually have a fibrosed ventricle. Okay, in restrictive cardiomyopathy, the fibrosis is within the myocardial wall, whereas in constrictive pericarditis, there is a casing of fibrosis outside of the myocardial wall. However, fibrosis is fibrosis, so the physical properties of fibrosis they are similar. Okay, so what ends up happening is often there is a limit to the amount of distension after which the ventricle no longer dilates. Okay, so as we've discussed this in our discussion on JVP, this results in a large V wave. The blood that was supposed to enter move from the left atrium to the left ventricle or the left right atrium to the right ventricle doesn't do so when the valve opens. Okay, and it is also associated with typically a large Y descent. Okay, now if you think about it a little bit more, a Y descent is due to rapid ventricular filling. Okay, now in constrictive pericarditis, early rapid ventricular filling is normal because the ventricular myocardium is normal. Okay, and the casing of fibrosis has not reached its tensile limit, so it has not been stretched. So you will get a rapid Y descent as would be expected. However, in restrictive cardiomyopathy, what ends up happening is there is a problem with the myocardium itself. So usually, but not always, there is a impaired initial early diastolic filling relaxation of the ventricle as well. Okay, so what we end up having is a large V wave, and usually we don't have a rapid Y descent. So although I had discussed in the JVP discussion that a large V wave is typically associated with a rapid Y descent, this is the exception to that rule. Okay, so the first thing is we can use the absence of a rapid Y descent to differentiate. The second thing is both ventricles have a decreased LV end diastolic volume. So both ventricles are going to try to maintain the stroke volume by contracting vigorously. So because of that, we usually have a very prominent X descent. Now, there are some additional findings that may or may not be there. So one is that in restrictive cardiomyopathy, you can have a third heart sound, but like I said, if the rapid Y descent is rare, similarly the third heart sound is also caused by rapid early filling, so that also would be rare. So both of these findings would definitely are related to each other physiologically speaking. Their hemodynamics are common, so you would get a common both of them would be rare. Lastly, restrictive cardiomyopathy may be due to either fibrosis, or we'll come to this in detail in our discussion on cardiomyopathy subsequently, It may be due to infiltration within the walls of the ventricle by amyloid, by other inert substances. So those substances are not electrically active, okay, unlike the myocardial membranes, cell membranes. So as a result of that, even though the wall of the ventricle is thickened on imaging or even normal in imaging, okay, what you end up finding is that the ECG is showing low voltage complexes because there is a non-conducting material in between the myocardial and the surface lead that you placed on the chest. So you may have decreased ECG voltages, but see, this is much more so with amyloidosis and not with other cases of right ventricular restrictive cardiomyopathy or ventricular restrictive cardiomyopathy. So this is not something that we can reliably use. So the fact that there is no pericardial knock or exaggerated third heart sound and the absence of a rapid Y descent in the presence of a large V wave, okay, that is what indicates to a clinician that it is restrictive cardiomyopathy and not constrictive pericarditis. Okay. However, as you can see, and I have shown it in the diagram, you can still have a rapid Y descent, okay, in some cases of restrictive cardiomyopathy. In that case, it becomes very difficult for us to clinically, based on a physical exam, differentiate patients into one category or the other. So as you can see, both restrictive cardiomyopathy and constrictive pericarditis may have large V waves and rapid Y descents, but a rapid Y descent is rare in patients with restrictive cardiomyopathy. Second thing is the other things like low voltage ECGs and the presence of a pericardial knock are, they lack clinical sensitivity or, they lack the sensitivity and specificity to be clinically useful. So what do we do? Okay. If we have a large V wave, okay, the absence of a Y descent will be able to differentiate between restrictive cardiomyopathy and constrictive pericarditis. Okay, and in restrictive cardiomyopathy, this is because during early diastolic filling, there is a impairment of ventricular relaxation, which was what was responsible for causing early rapid filling, if you recall. Now, on the other hand, if we compare the other two entities, that is RVMI and RV hypertrophy. Okay, so RV hypertrophy versus RVMI. So both of these conditions, RV hypertrophy and RVMI, have impaired early relaxation. Okay, so why do they have impaired early relaxation? The hypertrophic myocardium decreases the RV and systolic volume, and the second thing is hypertrophied ventricle is more likely to be ischemic, not get adequate blood supply, and therefore its relaxation, which is also an active process, requires energy, would be impaired. Similarly, RVMI would also have ischemia of the ventricle and therefore impaired relaxation. So when you have early impaired relaxation, okay, blood keeps accumulating in the atria, and at the end of the diastole of the ventricles, the atria contract, and that pushes blood into the ventricle, but the atria need to develop a high pressure in order to push blood into the ventricle, so you get a large A wave. Now we've already discussed this. Whenever there is a large A wave, that typically implies that there is a decreased compliance of the ventricle distally. So because of that, during early rapid filling of the ventricles, you will have a decreased Y descent. Okay, so this is common between both these pathologies. So this does not differentiate. Okay, what does differentiate is the fact that, see, the X descent, why does it happen? Okay, so the X descent is initially the result of atrial relaxation, followed by the contraction of the ventricle. So if you remember, this is the A wave. This is due to atrial contraction. So as the atria starts to relax, there is a decrease in pressure within the atria. After that, the ventricles start to contract. So when initially the ventricles start to contract, the pressure during isovolumetric contraction, the pressure within the ventricle increases. Okay, but the volume doesn't decrease. So as the volume does not decrease, the tricuspid valve leaflets, protrude into the left atrium, decreasing the left atrial volume and slightly increasing the pressure. So this is what we call the C wave. Okay, and after that, the remainder of the X descent is because of What it is, because the ventricle is now contracting but decreasing in volume, because during ejection blood is being pushed out of the right ventricular outlet, and as a result the ventricular intraluminal volume is decreasing. So that pulls the mitral leaflet or the tricuspid leaflet towards the apex of the right ventricle. So that is the isoform that we get. So whenever you have a hypertrophic cardiomyopathy, there is ventricular hypertrophy. So even though it cannot relax adequately, typically it can contract very well, because the relaxation is not just due to ischemia, it is also because of just the large size of the intraventricle, and therefore the decreased RV and diastolic volume. On the other hand, when you have a right ventricular myocardial infarction, at that point, see, there is ischemia. Both active processes, that is ventricular relaxation and contraction, are defective. So you will typically have a absent or a absence in the rapidity of the X descent. There will be a decrease in the rapidity of the X descent, or the slope of the X descent. Okay. Now, RV hypertrophy can have a fourth heart sound like any other type of hypertrophy. Okay, and RVMI may have a third heart sound. But as we discussed in the case of RV fibrosis, this kind of third heart sound is again rare. Okay, what you might get is ECG changes in RVMI, but we'll discuss this in the ECG series. You may need to place leads in on the right side of the chest. There are some other maneuvers that need to be done, and a detailed a dedicated review of the ECG just to look for RVMI changes have to be done. So we'll discuss that later. So we find is that RV hypertrophy can reliably be differentiated from RVMI based on the presence of a rapid X descent and S4. Okay. Now, however, see, as I've alluded to previously, if I have a large V wave with a rapid Y descent, okay, I cannot reliably differentiate between restrictive cardiomyopathy and our constrictive pericarditis. Okay, so this is the limit to our physical examination. Beyond this, it cannot really help us. So it is at this point that actually your echocardiogram may help you. So what do I do in this situation? I go for a echocardiogram. Okay, the patient has already undergone an echocardiogram. We do a detailed review of the echocardiogram and see if we have the findings that would be suggestive of one or the other. So typically your cardiologist would give you the answers to these questions already if you know where to look. However, if not, please ask for a repeat. Fine. So now, even though the physiology of restrictive cardiomyopathy and constrictive pericarditis is very similar, there are some notable differences, and those differences can be visible just by the morphology of the ventricles. So typically when these morphological changes are very obvious, it is they can both make the picture very clear, or they might slightly confuse you. So now, restrictive cardiomyopathy typically involves ventricular fibrosis of the right and the left ventricles. Whereas, as you can see in the diagram, constrictive pericarditis typically the organization of the inflammatory fluid typically occurs in more dependent and basal regions of the ventricle. So it tends to affect the tricuspid annulus lateral aspect more than the medial aspect, because the medial aspect is actually the septal aspect. So the septum is obviously nowhere in contact with the with the periphery or the outside of the heart. Now, so we typically get pericardial fibrosis in this location, and there is no fibrosis in the septal area. Okay. Then secondarily, we can also get findings suggestive of thickening of the pericardia, and sometimes, but not always, around 20 to 30% cases, we end up getting calcification of the pericardium. Okay, so these things do suggest constrictive pericarditis, but they are by no means definitive. So the first thing is pericardial thickness more than 2 millimeters, which is present in around 80% of cases. Now the second thing is pericardial effusion may be present. It is usually or often present rather. Third is you might get calcification in 20 to 30% cases. Now, on the other hand, in restrictive cardiomyopathy, what we find is very prominent atrial enlargement. Okay, so this is usually quite prominent, and there are concomitant regurgitant murmurs involving the mitral and tricuspid valves. So, regurgitant murmur or atrial enlargement would be very odd in patients with constrictive pericarditis. However, these are positive findings. They have high positive predictive value. However, if they do not present, you can't really differentiate between the two. So next, what do we do? We cannot differentiate reliably. Okay, so what do we know? We need to actually assess the hemodynamic pathophysiology. So for this, we have multiple measures, but only 3 of them actually hold up to scrutiny, statistical scrutiny. So what are those criteria? Those criteria actually have been summarized in a criteria called the Mayo Clinic criteria, published in 2014 originally. Okay, so this is the criteria. Okay, there are 3 echo parameters that can be used to differentiate. One is the ventricular septal shift, with inspiration and expiration, so the respiratory shift. Then a normal or slightly elevated medial E prime velocity. If you recall, the E prime velocity was the velocity with which the myocardial tissue at the mitral annulus or the tricuspid annulus was being pushed away from the probe as the ventricle relaxes during early rapid filling. So that is the most direct measure of ventricular relaxation that we have on an echocardiogram. Okay, and then finally we have a hepatic vein expiratory diastolic reversal ratio. Okay, so this is defined as the ratio of diastolic velocity, peak diastolic velocity, diastolic velocity to systolic velocity during expiration. We'll see how it is. If diastolic velocity, reversal velocity is reverse velocity is more than equal to 0.79 times the forward velocity, that is considered a positive finding. Okay, so the criteria suggested were that if you have a ventricular septal shift indicating ventricular interdependence, and either one of these 2 findings, the other 2 findings, okay, you have a sensitivity of 87% and a specificity of 91%, resulting in an LR positive likelihood ratio of almost 9.7 times. Okay, now see, so if all criteria are present, what ends up happening is the specificity naturally increases, but the sensitivity falls. However, if all 3 are present, that means the positive likelihood ratio increases to almost 21 times. Okay, so from 9.7 it goes to 21.3. So this is the Mayo Clinic criteria. So we'll delve into what are the actual imaging findings that we find. So the first thing we're going to talk about is the ventricular septal shift. So usually what happens is ventricular interdependence can help us differentiate between right ventricular fibrosis and constrictive pericarditis typically. Okay, however, interdependence is more typical of constrictive pericarditis than RV fibrosis. Okay, so as you can see, this is what is interdependence. What happens is during inspiration, blood is pulled, as we've discussed previously. Around 15 ml of blood is pulled into the right ventricle. Normally, the right ventricular free wall is dilating at this time during early rapid filling. So that extra blood is accommodated by the increase in volume caused by right ventricular free wall dilatation. But however, in this ventricle, the free wall is fibrosed. So because the free wall is fibrosed, this blood has to go somewhere. So where does it go? It goes into the right ventricle and causes the septum to be pushed into the left ventricle. The septum is going a bit towards the left ventricle. This is during inspiration. During expiration, the reverse happens. Okay, so during expiration, there is a positive pressure within the chest. So because of that positive pressure, there is actually decreased flow into the right atrium, and therefore decreased blood coming into the right ventricle. So because of that, the septum moves in the opposite direction. Okay. Now what we find is that ventricular interdependence is not pathognomic of constrictive pericarditis, but naturally, like I've just discussed, is highly suggestive. So what we can do is we can just put to an M mode scan passing through the right ventricular free wall. So this is the right ventricular free wall, and if you would notice, it's not moving much. Okay. The second thing is through the septum. Okay, so this would naturally be a parasternal long axis view. So this will be the RV free wall. This will be the septum, the interventricular septum, and then we have our LV posterior wall. Okay, and actually we've also done respirometry along with it. So these are the respiratory movements. So what you can see is during inspiration, so this is inspiration, this is expiration, and this is inspiration again. So during inspiration, the septum is moving away from the RV free wall, okay, and towards the left ventricle. The other thing is during inspiration that is happening. During expiration, the reverse is happening. So the septum is now moving away from the left ventricle and towards the right ventricular free wall. So this is the septal movement with inspiration and expiration, and like I said, it is highly suggestive of your pathology. Okay. Now, if you do a B mode 2D echo, okay, and you take an apical 4-chamber view, as we've discussed during our discussion on JVP, the characteristic problem with a constrictive pericarditis is that there is a limit to the filling of the ventricle. So during mid diastole, suddenly the dilating ventricle reaches a limit beyond which it cannot dilate. Okay, so when it reaches that limit, a very interesting thing happens to the septum. Okay, there is an abrupt cessation of the ventricular dilatation. Is more prominent on the right ventricle. It can happen with the left ventricle as well. So this is called diastolic checking. So the ventricle is moving towards the left ventricle and suddenly it stops. Okay. Now this would happen. This would be more obvious during inspiration naturally. The other thing that happens is because it has suddenly stopped. Okay, its momentum has been suddenly stopped, and the fibrous tissue within the the ventricular myocardium or in the pericardium causes it to snap back, okay, towards the right ventricle, and that process is what we call septal bounce. So this combination of diastolic checking followed by septal bounce. Diastolic checking is towards the left ventricle and septal bounce is during the is back towards the right ventricle. Okay, now see, this is a septal movement towards the right ventricular free wall during inspiration. Although during inspiration, mostly the septum is moving towards the left ventricle, but because of this, every action has an equal and opposite reaction. This sudden checking of the movement causes the septum to move transiently back towards the right ventricle, and that is what we call a septal bounce. I have not put a good video of this, and this is something that you would see in a B mode ultrasound in an apical 4 or 5 chamber view. So that is something that you would have to go and see in your echo lab or in your echocardiography room. Now, similarly, if I was to diastolic checking and septal bounce, and I was to do an M mode ultrasound, okay, I would get something very interesting. Okay, I would this kind of movement of the septum towards the left ventricle, then towards the right ventricle, and then back and forth, that produces an oscillation. Okay, that oscillation is a very interesting thing because it ends up producing this kind of a undulation. Okay, this undulation is what we call your shudder. It happens at the center or the middle of diastole. So that is called mid-diastolic shuddering, and it is most obvious on M mode ultrasound. So for this, the line of interest has to be placed perpendicular to the septum in the parasternal long axis view with a concomitant respirometric tracing. So that is what we call a ventricular shudder. So this, if you can see, this is your shudder. Okay, so till now what we've discussed is the expiration versus inspiration changes in the septal position, and if you were to do an apical 4-chamber view, you would find what we discussed is diastolic checking and septal bouncing back, and this on an M mode appears like shudder. Okay. Now, the second thing is that the anatomical distribution of fibrosis, as I've just discussed, is different in restrictive pathologies like RV fibrosis and constrictive pericarditis. So, see, here in constrictive pericarditis, we have fibrosis only involving the lateral wall of the tricuspid annulus, whereas in case of restrictive cardiomyopathy, it is involving both annuli, both sides of the annulus. So, when we check the medial versus lateral E prime velocity, there will be a difference. Okay, so even in the left ventricle here, there is a lot of there is fibrosis, definite fibrosis. Here, the septum is definitely spared. There may be involvement of the lateral annulus. Okay, so in either valve, that issue will be there. So we can use this to our advantage in diagnosis. So tissue Doppler will show you differences in the medial versus lateral E prime velocities. So what we find is this is the medial E prime velocity. The medial E prime velocity of either valve is actually the corresponding to the movement of the base of the septum. Okay. Now this is an apical four chamber view. So therefore the septum during early ventricular filling would be moving away from the probe. Why would it be moving away from the probe? Because the ventricle is dilating. Okay. So the annual medial aspect of both annuli would be moving away from the probe. So what we find is that the medial E prime velocity here is preserved. Okay, actually, if you look at it, it's slightly elevated. Okay, you don't expect a medial E prime velocity of between 12 to 18. It's coming here. It's quite elevated. It's 15 probably. Okay. On the other hand, what we find is that the lateral E prime velocity is lower than expected. Now, if you recall, it was the lateral E prime velocity that was typically larger. Okay, it was a normal value was a E prime velocity of more than or equal to 11 meters per second. This patient has a E prime velocity of around 8. So the lateral E prime velocity is decreased, but the medial E prime velocity is normal. So this indicates that the annulus of the atrioventricular valve, mitral or tricuspid, is tethered. Okay, in this case we are checking the mitral valve, so it is actually tethered. No, actually we are checking the tricuspid valve. Okay, so it is actually tethered to the pericardium. Okay, indicating there is pericardial fibrosis. Okay, now there are two eponyms that have been used to describe these findings, and they cause a lot of confusion. One is what we call an annulus paradoxus. So this is basically, as I've discussed in our previous discussion, the capital E by E prime velocity ratio is directly proportional to the left atrial pressure. But because here what is happening is that the medial E prime velocity is being exaggerated. Even though the left atrial pressure is elevated, the ratio of E by E prime changes. Okay. So what happens is, as is normally expected, the E wave in grade 2 diastolic dysfunction would start to increase. In grade 1, it would be slightly decreased and then it would start to increase. Whereas the E prime velocity here is actually increased rather than being decreased. So the ratio is not going to increase. The ratio is going to fall. So the normal linear relationship that you have between E by E prime velocity and left atrial pressure no longer is valid. And that is what we call a annulus paradoxus. It refers to the exaggerated medial E prime velocities. Okay. Then we also have something called annulus reversus. Okay, so what is this? This is a reduction in the lateral E prime velocity to values resulting in values that are lower than expected. Again, this is typically, the lateral E prime velocity is much more than the medial E prime velocity. So here what we find is the reverse. Okay, so even if there is a diastolic dysfunction, in a normal diastolic dysfunction, you have lateral E prime velocities still being higher than medial E prime velocities. Here, however, the reverse has happened. Okay, so the lateral E prime velocity is predominantly affected. Now, last thing that we need to look at is the diastolic reversal in the hepatic vein. Okay, so in the hepatic vein, and this will be a discussion I will be discussing hepatic vein hemodynamics in order to review right atrial pressures in the next discussion, pulmonary hemodynamics. However, bear with me for this particular finding. So what we get in the hepatic vein is actually a forward flow and a reverse flow. Okay, so this is the forward flow and then you have a reversal of flow, and similarly you have a forward flow and then you have a reversal of flow. So this is in a subcostal view. So forward flow is towards the right atrium and therefore away from the probe. This is the right atrium, this is your IVC, and this is your hepatic vein. So blood from the hepatic vein into the right atrium would be moving away from our probe, which is kept here. So it would be moving away from our probe, so it would show negative waves, and reversal of flow, that is away from the probe, towards the probe, would show positive waves. Okay, so that is what we are looking at. So what are we looking at now? We find that there is a during inspiration there is more forward flow, and progressively during inspiration it is increasing. Okay, it is becoming more and more. So this is what we would expect. During inspiration there is negative pressure within the chest wall, so that is sucking in blood into the right atrium, and that is also causing a shortening of our reverse flow, that is flow in the hepatic vein that is away from the right atrium. So there is a gradual falling down of the reversal of flow. However, during expiration, what you find is that as a result of ventricular interdependence only, there is an exaggeration of the reverse flow. So forward flow is naturally going to decrease. Okay, it will again increase as during inspiration, but in the first beat after expiration, you find something very odd. You find that the reverse flow is now somewhere close to the forward flow in terms of absolute magnitude. So the forward flow here is around 3, okay, and the reversal of flow is almost 4, if you can see, meters per second. So that is what we see. So like I said, if it is more than 0.79 times that the forward flow, then if the reverse flow is more than 0.79 times the forward flow, that is another feature related to constrictive pericarditis. There are some other features also that help you differentiate. One is that you can take a color Doppler tracing from the mitral valve. Okay, so if you find a increased EVA velocity after expiration, okay, so in the first beat after expiration, so what happens here is during expiration, okay, there is a positive pressure within the chest wall, and that positive pressure is essentially decreasing right ventricular filling. So as a result, the septum is now not moving as much towards the left ventricle, so flow across the mitral valve is actually exaggerated during expiration. Okay, so that is what you get, that there is an exaggeration of the flow across the mitral valve, and that flow is obviously during early rapid filling, so you get a E wave velocity after expiration that is more than 25%. There is a 25% increase in the E wave velocity in inspiration versus expiration. Okay, so expiratory E wave velocity is 25% higher than the inspiratory E wave velocity. Okay, now on the other side, we have taken a color Doppler, a continuous wave color Doppler, this thing tracing has been taken from the tricuspid valve. Pardon me, this was also continuous wave Doppler. What we get is a very interesting finding. So what we get is that there is a decrease during expiration, there is a decrease in the E wave velocity. This would be expected. Okay, during inspiration we have increased E wave velocity, and during expiration we have decreased E wave velocity on the right side. Okay, again indicating ventricular interdependence. So okay, so there is a decrease in the expiratory E wave velocity which exceeds 40% as compared to the inspiratory E wave velocity. So during the first beat after expiration, this is what happened. Okay, so this doesn't exceed, rather it is the difference exceeds 40%. So this is more than or equal to more than 40% lesser than the inspiratory E wave velocity. Okay, that is what that means. Okay, the next thing that we can show is a diastolic flattening of the posterior wall of the left ventricle. Again, because the left ventricular free wall, the posterior wall is not the free wall, the posterior wall is tethered to the pericardium there. Okay, so during diastole it should be rounded, because the normal contour as we've seen of the left ventricle is like this. Okay, but here what is happening is that the posterior wall is actually flat. Okay, so it is flat during diastole. So what we do is we actually take a parasternal long axis view and pass the line of interest through the septum and the posterior wall. Okay, so what we find here is that during diastole, so this is the left ventricular lumen, this is the interventricular septum. Now we are going along as time goes by, and what we end up finding is the left ventricular wall during systole, and then during diastole there is usually a flattening, okay, a complete flattening of the left ventricular posterior wall, again highly suggestive of constrictive pericarditis, because this kind of isolated ventricular flattening would not occur in restrictive cardiomyopathy. So these are the findings that we have that help you differentiate between your restrictive cardiomyopathy and constrictive pericarditis in case there is a large V wave with a rapid wide descent. So if there is no rapid wide descent, you're pretty sure already that the patient has a restrictive cardiomyopathy. Okay, so most cases a physical examination is sufficient. However, in this particular scenario, you will require a detailed echo evaluation. So now we'll be going on in the next video, which will be this last in our series on echocardiography for internists, to the assessment of right ventricular function and pulmonary hemodynamics. So thank you, and I'll see you next time.